Good morning. Okay, let's see. So I am a clinician. I want to emphasize that. So I have been in the battlefield for almost 40 years now. And over these 40 years, things have changed quite a bit. And I think we are understanding the newborn way better than we used to. And we used to do so many weird things in the past. Now it has become very organized to the point that it's almost too organized for a clinician. So, a story to tell, a birth. A childbirth is a time when there is a sudden change, a physiologic change, the unique change that a human will go through and will never have to go through again. And these changes are, you're moving to a world of parasitic life in the womb to an outside life where you are on your own, in the world, the womb to the world. And most of the babies will do well, but there are at least 10% who will have problems, and these are the ones we'll have to help. And you don't always know who are these 10%, so which means you always have to be ready. And so how can we be ready? And over the years, we have accumulated knowledge, thanks to the researchers. And we have now few guidelines, good techniques in the delivery room. It's called newborn resuscitation program. It's neonatal resuscitation. It's not that we resurrect a dead baby. We just help the baby to go from depending on his mother for everything to being a free human being and doing it on his own. The baby will be he, the mother will be she, even though there are babies who are she, but just so that you know who we are talking about. So there are guidelines that are continuously refined, and this is what happened now. We are ending up with having a 7th edition, and these guidelines are getting extremely complex. And we decided, the NIS decided that it was worth it to have a little conference about this. So I think you just read what I put there, so I'll go on. Life is mysterious. Life is depending on an organ called the placenta. The placenta is the tree of life. You probably know about in mythology, philosophy, religion, mysticism, the tree of life. It's a tree from which life spurts come. The placenta also, it looks like a tree. This is a very interesting analogy, but because also it could look like a brain. There is all these associations that clinicians have a tendency to do. This is the source of life, the placenta that we throw in the bucket. We should not. It's very important. So let's talk about birth transition after this little philosophical talk here. And so the placenta is really where the fountains of life is. It's a mixture of blood from the mother. It first goes through the uterus, meets into the placenta, mix venous and arterial blood, makes little rivers and lakes from which the fetus will feed and get its oxygen. The placenta is really the machinery that permits life to go on. So the placenta, you see, I'm praising the placenta here. It's so important to the point that if you put a clamp on the cord, you displace the fetus from the placenta. This is the dramatic moment of birth. Is that fetus going to be able to become a newborn? Without his support, without his tree of life, is he going to be able to do? And that's where you will come in handy to help that little one to go on. So there is a sudden and massive transition happening at the time of birth when you cut the cord, when you let the placenta go. There are major lung changes, major circulatory changes, and then the temperature will be also another problem that we'll have to address, because he's coming from a milieu that looks like a sauna, and then you will throw this little one. Don't worry about the notes, because I probably will lose them in a minute. And then the baby is thrown into, for example, a C-section, OR. What's the temperature in an OR? We have been fighting with the obstetricians for years to increase the temperature. So the little baby who was a fetus in a sauna is thrown into an icy icebox, wet and naked. This is a huge transition. The baby who used to be a little fetus, he was a little fish bathing in fluid. Now he's a little bird flying in air. How is he going to change so quickly? And he has to do it very quickly. Again, that's when you are coming into action. So the circulation changed quite a lot after birth. When you are a fetus, you have, let's see, okay. So you have dependency on the placenta here, and then you will have a ductus venosus, foramen ovale, and then you have your ductus arteriosus here someplace. Can you see? Yeah. So intrautero, you can have all the cardiac anomalies you want, it does not matter. Because of all these shuntings, it can survive. I'm talking about that because yesterday I had a baby who had a complex congenital cardiac anomaly, so complex. He was okay to live in his mom's womb, but as soon as he was born and we cut the cord here, all these little shunts are gone, and the baby will have to do on his own. He will have to close everything and take the oxygen from the lungs. The closing of all these shunts made that baby not possible to live. He died very quickly after delivery. So these circulatory changes at birth are very, very important and very dramatic. Because intrautero, your lungs are bypassed. Okay? You get a tiny bit of blood, maybe 8% of the circulation intrautero, but the lungs are useless intrautero. They are just full of fluid. They don't do anything. The placenta is the amazing machinery that will give nutrition and oxygen to the baby, to the fetus. Oxygen is the fuel of life. If you don't have oxygen, nothing functions. Now, if you cut the cord, where is that newborn going to get his oxygen? It will have to go in the lungs. And to go in the lungs, it's possible only if the baby is strong enough. It's possible only if the baby is term, going through labor, no pathologies, and mostly the vaginal births are much better than the C-section births. But this is the lungs is the organ that will permit to the baby to get his oxygen once you cut the cord. So you go from one organ, the placenta, that gives oxygen gas exchange to the fetus, to the other organ, the lungs, and the lungs are even way better at giving oxygen to a body. So the success of transition is to go through at least shunting, closing all these shunts, and be sure that the oxygen that you get now from the lungs will come in the left atrium to the left ventricle, and this will give oxygen first to the coronary arteries so the heart muscle can pump. If the heart muscle doesn't get oxygen, it will not pump, will become bradycardic. And after the coronary arteries have given oxygen to the muscle of the heart, it can go to the next exit from the aorta, which are the carotid, and the brachiocephalic, mostly the right one, will give oxygen to the brain and the right arm. And so your next organ to get oxygen to live is the brain. The heart is the pump that sends the oxygen to the brain. The brain is the computer that will tell the body how to live. If you don't succeed in these two steps, the rest of the body is going to fail. So what is the transition in a few words instead of a lot of blah blah? So you go from intrauterine life to extrauterine life. Intrauterine life, you depend on the placenta. Oxygen is coming from the mother's blood, no other places. The lungs are fluid-filled and are not used intrauterine. They are just growing. They are full of fluid. Blood flows to the lungs is very low. It's just enough to feed it so it can grow, but no mechanism, no physiology, nothing is going on other than trying to grow. And then you have all these shunts that bypass the lungs because they are useless intrauterine. You have the placenta to do it. Now, to go to the extrauterine life, when you cut the cord, you will now depend on the lungs. And the lungs will have to be filled with air. There used to be fluid in it. It has to be replaced by air. And this is the biggest ordeal for a lot of babies. It's hard to put air in lungs full of fluid. The pressure of the fluid is much higher than the pressure of the gas. Room air is a gas. If you see water boiling in a pot, you see the water stays in the pot, but the water vapor comes out of the pot and pushes the lid out. The gas doesn't want to stay with the fluid. So the baby will have to absorb the fluid. And there are at least 10% of these babies who cannot do it. So after birth, the lungs have to be air-filled. And then, when that happens, there is a lot of oxygen, because we are going to talk about how much oxygen is in room air. And this dilates the vessels in the lungs, and suddenly there is a rush of blood in the lungs, and the flow to the lungs increase, the resistance decrease, the shunts close, and here you are, you're a human. So this is what happened. Intrautero, the alveoli is full of fluid. There are sodium channel pumps that keep on making fluid. After birth, these channel pumps reverse. They try to empty the alveoli from fluid. This is one chemical way to do it. There is also a physical way to do it, and this is where we can intervene, and we are going to talk about that. We also can intervene for the chemical way, which is actually the steroids. What happens is that during labor, the mother increases her secretion of thyroid hormone, steroids, adrenaline, everything is like this. So it affects the sodium channel pumps. It slows them down. There is less fluid being made. And then during labor, there are contractions that push the little fetus, like this, all over the place. It pushes on the diaphragm pushes on the lungs, and there is some fluid that can come out in the amniotic fluid, and if the baby is healthy, he can close his glottis. And then during the passage through the vaginal canal, there is also some squeeze of the upper airway. So a term healthy baby who goes through labor and has a vaginal birth and has no pathology already has less lung fluid than a preterm baby who has a repeat C-section scheduled, no labor, and he still is making fluid, and then you yank him out of his mom, and his sodium channel pump says, uh-oh, I have to reverse. So these are babies who have way more fluid to deal with. On top of it, they are a little preterm, and so they don't have the strength and the stamina to push the gas against the pressure of the fluid. Remember the boiling pot? So let's talk about the lung transition. There are two important parts of the lung transition. The airflow, it's to put air in the alveoli, and the blood flow. So airflow, you have to lose that lung fluid. And that's where you get in trouble. You have these babies who take 4 to 6 hours of grunting, retraction, and these are the babies who try to get rid of their lung fluid, goes into the interstitial tissues, should be absorbed by the lymphatics and the vein, but somehow it stays in the interstitial tissues and has a tendency to go back in the lungs. It takes 4 to 6 hours for this to equilibrate and for the baby to eventually pee it out. To get rid of the lung fluid, you also have, before you can start any good, efficient ventilation, you have to establish functional residual capacity. It actually means you have to build up your lungs with a reserve of air before you can use a small tidal volume to breathe comfortably. This is a especially great effort that the babies have to go through. And if they are not term, healthy, going through labor, vaginal birth, you know, the whole shebang, if they will have problems, or they will have too much fluid, or they will not have had some help during labor, or they are too young, or they are sick, so they don't have the stamina to put enough pressure there to keep their glottis closed so that they can push the fluid, the air against the fluid and build some reserve of air. Nobody here does not have a functional residual capacity. You all have it, and that's why you can breathe without me hearing anything. But if you don't build that, the baby will have difficulties with gas exchange and will have to work harder. If you keep some fluid in the lungs and you cannot have a complete functional residual capacity, there will be fluid. It will impede the gas exchange. And the baby will have to use more strength. And he's already weak because he's preterm. And so these are the babies who are grunting, retracting, tachypnic, and you don't know what to do with them. I will tell you what to do. You will put a lid on them. No, after you build the functional residual capacity, there is also necessary to keep this alveoli open. And so for that, it's a good idea to have some surfactant. Most of the babies after 35, 36 weeks will have enough surfactant. The late preterm may have enough, but not on all the alveoli, and the very preterm won't have any. So now we have the steroids, which has changed quite a bit on how we take care of newborns, and actually has pushed the limit of viability amazingly far, because I remember when I was a young fellow, several years ago, we could not save babies who were less than 30 weeks. Now look at what we do. We're talking of 23, 22 weeks now. So this is what happened for the air. You have to build residual capacity and you have to have enough surfactant to maintain this. At the same time, if this is successful, then you have introduced enough oxygen in the lungs to dilate the blood vessels there, the arteries. And therefore, the resistance will decrease, and the blood that was intrautero going through the foramen ovale and the ductus arteriosus, now, because you put the clamp there, the resistance in the body is so much higher. Now this blood says, too complicated to go there. I'm going in the right ventricle, and I will go in the lungs, because now everything is relaxed there. And so the flow will increase in the lungs. And this flow will therefore close all the shunt that you had before birth. The babies who cannot close their shunt are the babies who get again in trouble. They are the ones, for example, who maintain their fetal resistance, and these are the babies who go into prolonged pulmonary hypertension of the newborn. These are the ones who can end up really in a NICU in big trouble. So it's so important to be able to put that air in these lungs so that the blood can go into the lungs, close the shunts, and make a baby out of a fetus. So what is functional residual capacity that I'm so pushy about? Well, this is intrautero. This is the fluid in the lungs. And then if you start ventilation, you put air instead of that fluid. You push the air in and you try to have this fluid absorbed, and you build your functional residual capacity. And you will use, and you will use only this part of the lungs for breathing. So it's called the tidal volume. And this is a very easy, peasy breathing. But if you have not filled up with air and you still are dealing with fluid there, the gas exchange is difficult and the breathing will be difficult. So this is what you want to succeed in the delivery room. It's changing this to air, building air there and use this only for breathing. And this is a picture that I really think is so cool. These are rabbits. X-ray of rabbits. And this is a rabbit who hasn't taken a breath, and it's full of fluid. And then the rabbit is taking his first breath, and the air is replacing the fluid in the lungs. And this is done very quickly. You see, these are seconds. By 20 seconds, half of it is there. By 30 seconds, he's almost ready to breathe comfortably. This is what we want to achieve in the delivery room. It's helping these babies who cannot do it on their own. Now, in the new NRP, they talk a lot about delayed cord clamping. And the delayed cord clamping is actually a more physiological cord clamping. It's more physiologic, because if you would look at natural childbirth, it's never cut right away. Most of the midwives, they wait until the cord stops pulsating. In the animal kingdom, it's the same story. So it's only about when birth became hospital deal, that's when suddenly there was this early cord clamping. In the 50s, we thought technology would take over and nature was put in the back burner. Good luck, nature is coming back. So delayed cord clamping is actually more physiologic. If you think about it, the fetus gets its oxygen from the placenta, like I kept on telling you ad nauseum, and this oxygen is useful while the baby is being born and until he can take his first breath. So if you cut the cord and the baby is not breathing, where does he get oxygen? Nowhere. He's like a scuba diver who forgot his tank of oxygen. And no matter how much you flap and slap that scuba diver, he won't be able to breathe because he forgot his oxygen tank. So if you let the cord going, the baby is still getting something. And that's when, I don't know if you know about that, but that's when we do some surgery on babies who have airway problems. It's called exit procedure because it's done while the baby is still attached to the placenta. So he's still getting something, and we can put an airway if necessary. So the delayed cord clamping has a big emphasis on the new edition of the NRP, and it makes sense because the placenta is going to fill up the heart of the baby, of the fetus, baby fetus, because he's out but he's still attached. And it will fill up the heart and will be able to fill up the left heart also, because if you cut the cord and the baby is not breathing, which means there is no blood going in the lungs, so there is nothing going in the left heart. And so the cardiac output actually decreases. But if you keep the blood going, then this left heart is still getting blood. So this is the interest of doing delayed cord clamping, which is really called physiologic cord clamping. And I mean, that big emphasis on the 7th edition. So understand that the more you delay starting ventilation after you cut the cord, the more damage there will be, the more difficult it will be to catch up the baby. So you will get in trouble, for sure. And who gets in trouble? Well, in the term babies, it's mostly babies who have congenital anomalies or placental problems. Because if the placenta is not functioning well, then your baby doesn't get what he needs, and then he will have a hard time to go through labor, and certainly a hard time to go to the next step, being a newborn, because he already has a very low reserve of oxygen. And the more you delay the starting of ventilation, the more problems, the more difficult it will be. So that's for the term babies. Preterm babies, they have their own problems. Their problems is that they are immature, they have poor reserve, they may have been like chronic disease, chronic state because the placenta is diseased, the mother is sick, she has preeclampsia, which is our daily bread at OU, and they have somewhat surfactant deficient. So a lot of these little guys could get in trouble. So who will need resuscitation? And I would say, instead of giving you a whole list of reasons to do newborn resuscitation, I would say any baby who is too depressed to initiate the first breath. So somebody asked me what to do if the baby is so flaccid, there is nothing. Just start ventilation. This is more important. I hope you understood now why it is important. Because if you don't put air in the lungs, there is no dilation of the vessel, there is no blood going in the heart, the coronaries don't get blood, the heart muscle cannot pump, then it doesn't go in the brain, the computer cannot function, and the baby fails. So it's ventilation. We're not talking about adult CPR. We're talking about starting ventilation in somebody who never took a breath. And so, who needs help? Well, 90% of the babies will surprise you, they all do well. You just dry them and give them a kissy, goodbye, go to mommy. But then you have a few little lascar, they don't do as well. About 10% may need your help. And then of these 10%, 1 to 2% will really need a big help. And that's when, you know, your knowledge in newborn resuscitation will really be very important. So, can you really anticipate some babies who will need resuscitation? Yes, Dr. Shields says. I say, maybe. It's not that clear. For researchers, it's much clearer. But for clinicians, it's like, woo, hocus pocus. Okay, but first question, is the baby born at term? Because that really makes a big difference. Because term babies usually do okay unless you have congenital anomalies or have had some asphyxiated episode that the obstetrician these days can pick up with their fetal monitoring. Now, is the amniotic fluid clear? Well, guess what? We used to ask that. We still should ask it, despite what the researcher says. I still think that means, okay, in the new NRP they say don't suction these babies, just start ventilation, which makes a lot of sense. If you have no ventilation, nothing works. But if the amniotic fluid is stained with meconium, it means that that baby at some time had hypoxic episode intrautero. It means that this baby is risky. It means that this baby could be in your 10% who needs resuscitation. So meconium babies, they still need people who can intubate in the delivery room, who can do, full resuscitation. You don't suction because you want to suction the meconium. You don't intubate because you want to suction the meconium. You intubate because he is not doing well with his breathing and you have to go through the process of NRP, which is, mask ventilation, failing. Next step will be airway, probably intubation. So meconium doesn't need to be suctioned if the baby is crying or breathing, but a meconium baby can give you problems and can still need intubation for ventilation. So you see the difference? Yes? And then if a baby is breathing, do you need to resuscitate? No. Does he have good muscle tone? Then no. So these are the question. If you say no to all of them, you're okay. But these are simple questions. Actually, the real life is a little more complex. So gestational age will have an influence on physiology. Like I talked before, for the preterm, our biggest problem is weak, and the surfactant will be missing sometimes, which make the lungs stiffer, difficult to ventilate. Meconium babies, like I told you before, they can still obstruct their airway. It's not that you can suction it, but it will affect the breathing in these babies too. So gestational age may have some importance. But the very low birth weight babies is really the one who will give us all sorts of troubles. This little one. It's up to 1.5% of live births in the US. It requires your help, and more than 75% of them will be admitted to an intensive care unit. And the mortality rate is much higher. So we have to focus on them, but let's not forget the term babies too. They are important people too. Now, the time to the first breath, in 1998, Dr. Sogstad was studying asphyxiate babies versus babies, asphyxiate babies who were resuscitated with room air versus 100% oxygen. And he came up with a good response to newborn resuscitation is when the baby takes his first breath. And his first breath is between 10 to 15 seconds, very fast. The time to first cry, first your breath, then your first cry. So that means the babies can build their functional residual capacities in two breaths. Poof, it's done, if they are healthy. Time to first cry. Healthy babies, about 30 seconds. Asphyxiate babies, resuscitate with room air, 72 seconds. And asphyxiate babies resuscitate with 100% oxygen longer. And this was studied by Dr. Vento in 2001. Pure oxygen, 100% oxygen, seems to inhibit the respiratory drive of the newborn infant. Remember that. So if you have a baby who is born not breathing, is apneic at birth, what are you going to do? Stimulating the baby may be sufficient for one who has primary apnea. But most of them will need to be start on ventilation. Remember the scuba diver who forgot his equipment? So no matter how much you shake them, it won't work. And since when a baby is born apneic, you don't know if it's primary or secondary apnea. And most of the babies, if you don't start right away ventilation, it will get down to a whirlpool, and it will be so difficult to catch them up. So always focus on starting ventilation right away. Because of babies who don't breathe at birth, it could well be also that the placenta during labor was not doing its job. And that baby already has been hypoxic. And that's when the obstetrician shows on his fetal monitoring, category 2, 3, 2, 3, we have to do something. This is a baby who has no more reserve. And we cannot afford to try to figure out, is he in primary or secondary? No. We have to start ventilation, because if you cut the cord, there is nothing going there. And if you start ventilation, guess who you are helping? Mr. Pump, the heart. He, I call the heart a he. In French, it's a he. In Spanish too, no? Okay, eat, but that sounds weird. He needs his food, which is oxygen, the fuel of life. He needs his gasoline to go. So unless you ventilate and put oxygen in the vessels and it goes in the coronary arteries and bathes the heart with inner fuel, this pump is not going to work. So the heart rate is really the first organ that tells you how well the baby is going through the transition. This is why you use this pulse oximeter, and in the new edition they're starting to talk about using 3-lead EKG. It may pick up the heart rate better and faster than the pulse oximeter. I'm sure you have experience with your pulse oximeter that it takes 2 to 3 minutes to pick up anything. So you cannot depend on that instrument. It won't tell you what to do. It will just tell you how well you did. And again, none of these cardiac compressions on babies who are not breathing, it doesn't make any sense. I have seen babies who comes like this, but there is no breathing, nothing going on. It does not work. It's again slapping the scuba diver without his equipment. You have to ventilate the baby first. You have to put oxygen in the blood. You have to put oxygen in the lungs, the blood, and then you can bang, 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 and then this blood will move with the oxygen in it and will take care of Mr. Computer who needs his oxygen to live and make a baby. So ventilation is the main goal of newborn resuscitation. No ventilation, no baby. No life, nothing. Go home, you failed. So ventilation, ventilation, ventilation. So focus on ventilation. What is ventilation? Well, first you need to have an airway. So airway means no cork in the airway, no mucus plug, no blood clots, no ball of fat, no other stuff that should not be there. So you have to take that out first. You need a clear airway. Now, it's not good to do heavy suctioning. So there is a fine balance between the two. All you have to do is just suction here if there is a mucus plug, or most of the time that's what I see. It looks like a giant so you suction, so have a big suction tube. Don't have a 6 French, it doesn't work. A 10 or 12 French, because you take this, it can really be a big obstruction. So suctioning the rest is not useful. Don't suction the stomach. It doesn't help. And don't do deep suctioning, because deep suctioning is the stomach. You are not suctioning every alveoli in the lungs. If you can do that, you get a Nobel Prize. So suctioning has to be gentle, because it increases pressure in the brain, for example, for preterm babies, to the point that we don't even like to suction preterm babies. We wipe their little face a little bit if we don't like the dribbles there. And once we have a clear airway, then we can start ventilation, which is breathing. And okay, to have a clear airway, not only do you need to be sure there is nothing in the way, but on top of it, you have to position the baby in a certain way, because babies have very soft airways. They are so soft that if you bend too much the baby or hyperextend the neck too much, guess what? The wet noodle collapse, and you cannot go through it. So you don't have a patent airway. So positioning of the baby in the sniffing position, try to make your airway as horizontal as possible. Then how you put the mask on the baby, and we'll go over that at the skill station, but how you put a mask on a newborn is also very important, because you want to give a certain amount of pressure too. So you will want to put the mask pretty close to the face and actually avoid leaks. So you will put some pressure on the face, not too much, otherwise it goes vagal. But you will have to put the mask first on the chin, open the mouth, then on the nasal airway. And when you put that mask, you may, at the same time, unfortunately, also collapse the nasal airway because it's so soft. So the only thing that you have left is the oral airway. So when you put a mask, always be sure the mouth of that baby is open. And that's, Mr. Sopa talks about that. So open, get the mucus plug out, position in the sniffing position, and open mouth when you use the mask. These are very important procedures to keep the airway patent so that you can put the air in the lungs. Otherwise, it's like a dam and you cannot go through it. Now, what about oxygen? Let's talk about oxygen. Oxygen, if you give too much of it, it leaves free radicals in the body, free radicals in the lungs that can stay months and that can give some inflammatory reactions, cytokines cascade, and all sorts of problems. Too much oxygen is not good. It destroys the tissues. It damages, actually, the DNA of the cells. So you have to give just enough, not too much. A pulse oximeter will help you, but again, like I told you before, it helps you only to tell you how well you did. So it doesn't tell you how much to give yet. So you have to know that most of the studies that we have done on babies are mostly on term babies, and the saturation that you can obtain with your pulse oximeter, the first one at 1 minute will be very similar to the fetal saturation, because the baby is going through his first transition. But by 3 minutes, the saturation should increase, and by 3 minutes it should be close to 70%. 5 minutes, 80%, 10 minutes, 90%. If you remember these easy numbers, you will know if you have to give more oxygen or not. Otherwise, you should start babies on room air. Mostly term babies, they all should be started on room air, because room air, we're going to talk about room air in a minute, because I think Denise wants to ask questions. But, yeah, ask your question.
Okay, so this is where we're going to see if this works. So hopefully you still have your room open if you were able to pull it up earlier on Socrative.com. If not, I'll give you a few more seconds here to look. It's J8VITXHR. 1 on your device. So go ahead and click on what you believe is the correct answer, and then click Submit. The pressure of oxygen in mom's uterine vessels that feed the intervillous spaces. Is it A, 60%, B, 60 to 80 millimeters of mercury, C, 90 to 100%, or D, 30 to 35 millimeters of mercury? Okay, so I'm going to click on How'd We Do? Let's see if this gives us the answer.
Well, it's more than that.
Is it more than that? Okay.
It's okay. Do you have another question?
Yes. Do you want to discuss this one?
Oh, yeah. Oh. Okay, so first of all, the one who say percent, we're talking about pressure, not percent. Okay, so at least that's clear, no? Percentage doesn't mean pressure. Percentage is a piece of a pie. Okay, so now the other one. Actually, the B and the D, you're both right and wrong. So you're doing very well, actually.
Okay, you want to go to the next one?
No, I want to explain something. What goes in the placenta is actually venous blood and arterial blood from the mother, and it gets mixed in the intervillous. I mean, well, I'm going to talk about it in a minute, but still I want to say it now. It's mixed, and so the pressure there is very variable, depending on the good functioning of the placenta or what. But usually it's closer to about 50 millimeters of mercury. So both of B and D, you were okay, because it's a mixture, so good. It's just the percentage people, that was not good.
Now, question 2 is, what is the pressure of oxygen in room air?
So that's pretty slow. Okay. Is it done?
It's done.
Okay. Again, you know, pressure is not percentage. For the 17% who answer A. Now, C is the correct answer. So remember, that's why we had the first question, which was, I guess we should have looked at it better. But it doesn't matter. What I wanted to emphasize is that a fetus has a fetal hemoglobin. It can extract this oxygen from a very low pressure milieu and be happy. Hey, it's gone. Oh, well. The newborn, if he can extract oxygen from room air, he has a pressure that's 3 times higher than when he was a fetus. But he still has his fetal hemoglobin. So whoopee-doopie, he has plenty of oxygen. That was a little pause to wake you up in case you're sleeping. Okay. So let's talk about oxygen. Where does the fetus get his oxygen? I just told you. From where? Placenta, yeah. Remember? I glorified the placenta in the beginning. And so we talk about the pressure of oxygen in the placental blood is a mixture of arterial and venous blood. So let's say it's about 50 millimeters of mercury. And then when he's newly born, where does he get his oxygen from? Room air, yes. And where is that room air? In which organ? The lungs. And the lungs, remember, they are even better organ at exchanging gas than the placenta because there is just a fine 2 cells layer that the gas has to go through compared to the placenta where it's much thicker because of all the vessels and the fontaines and everything. So the pressure of oxygen in room air being almost 3 times more than 30 seconds ago when he was a fetus, the problem is not oxygen, it's to put air in the lungs. So this is, again, the mixture of blood. So the fetus has a fetal hemoglobin. It's not an adult hemoglobin. It's a hemoglobin that is very avid for oxygen. You may or may not know about the dissociation curve, and I don't really care if you know or not. But what it means that in the fetus, it goes more to the left, which means it can take oxygen at a lower pressure. In the adult, it goes more to the right. It gives away the oxygen. So a baby keeps his fetal hemoglobin until about 3 months of age. It slowly decreases. Unless you transfuse them to the wazoo in the NICU, then they get their adult hemoglobin faster. So let's talk a little bit about room air, because it still seems to be a little bit fuzzy in people's mind. What is room air? Room air is composed of different gas, and the most important gas in room air is actually not oxygen. It's nitrogen. First the plants, then the humans. So they get their nitrogen. About 78% is nitrogen, 21% is oxygen, and then there's argon, water vapor, carbon dioxide, and all sorts of other little gas. But it's all a percentage of the atmospheric pressure. The atmospheric pressure is what keeps your 2 feet on planet Earth. If you would go to the moon, the atmospheric pressure is much lighter and you fly away. So the atmospheric pressure on planet Earth at sea level is 760 millimeters of mercury. And that's what you breathe, and that's what keeps your 2 feet on Earth, and that's how you keep your bones working and your muscle working. Because if you go to the moon and you come back, because the atmosphere was lighter, you know what? You lose your bones. They have to do exercise in their spaceship. So at sea level, which Oklahoma is about sea level, and if the weather is good, you know, if there is a lot of humidity, then the pressure is different. But usually in Oklahoma, the atmospheric pressure is around 760 millimeters of mercury. So 21% of 760 is about 150, 160 millimeters of mercury. That's the big pressure that the baby can get if he can put air in his lungs. Lots of oxygen. You don't need to give more oxygen. It's there already. And let's see, this I could not avoid to put, I wanted to put that there, even though I'm sure Denise would not have agreed, but it's so cool though. It's the oxygen cascade. See, from the atmosphere to your mitochondria. Look what happened to the oxygen. So at sea level, you have a pressure of 160 millimeters of mercury of oxygen. Then, depending on how much water vapor, it decreases a little bit to 150 millimeters of mercury. Then it goes in the alveoli. And in the alveoli, it's diluted again, and it's about 100 millimeters of mercury. Then it goes from the alveoli to the arteries. And eventually it diffuses, and then it goes to the vein, 45 millimeters of mercury. If you would do a blood gas in an adult, that's what he gets, about PO2 of 100, and in the vein, the PO2 goes down to 45 because all the cells have sucked in everything they want to get. And then in the mitochondria, which is really the machinery of life, if that doesn't work, you have nothing. And the pressure of oxygen is down to 4 millimeters of mercury. But it's necessary for the cycle of Krebs, which is really the motor of life. Okay, just that's a little digression. Now, this is important the anatomy here is important because this is the aorta, you know, coming out of the left ventricle. And remember, if you have put oxygen in the lungs, it goes in the left ventricle. And guess who is the first one to get anything? The coronary arteries, the heart muscle. And guess who is the next one to get anything? Is the brachiocephalic. And actually the carotid goes to the brain and the subclavian goes to the right wrist. And that's why you put your pulse oximeter there. Because after that you could have a ductus. So this is a good anatomy to know, the coronaries and the carotids, the pump and the computer, the heart and the brain. And so that's why you put your pulse oximeter here on the right side. Now, this is interesting too. It's the blood gas after birth. And you will see that after birth, if you would take a blood gas at 10 minutes of life, look at the PO2. At 1 hour, at 1 day, and at 1 week, it's almost like adult level. So it takes that long. And so let's talk about the PO2 after birth. The PO2, if you would do a blood gas in intrautero, and you would get, where do you think you will have the best partial pressure of oxygen in a fetus? You don't have to think too much because it's on the slide. Where is, oh, here. Here it is. You see that? And did I not just tell you a few minutes ago that the partial pressure of oxygen in a healthy adult is close to 100 millimeters of mercury? I hope you heard that. And look, the highest pressure of oxygen in a fetus is in the umbilical vein. It's 27. It's very low, isn't it? Even though it's low, they can function. There is enough oxygen content because the fetal hemoglobin, the amount of red blood cells, and because the mother keeps the baby warm and she makes him not move because she has a uterus that has barriers. But this PO2 here is maintained all the way until it goes in the heart. And so in the fetus, it's the left heart that has the most oxygen, because it's from there that it will have to give oxygen to the heart muscle and to the brain. So in 10 minutes after birth, the PO2 will go to 50, and then the PO2 goes to 63 at about 1 day of life, and in 1 week it's to 70 and almost like to adult level. So it takes time to go up. It also, you have to know that during all this time, even though it's a little lower than the adults, the saturation is 100% because the baby has a fetal hemoglobin, which can zap the oxygen at very low pressure. So you have enough pressure after birth, enough oxygen after birth. But why do we need so much more oxygen after birth? Huh? 3 minutes left? Oh, okay. Why do we need more oxygen? It's because the baby is independent. He's not a parasite anymore. He needs more fuel to function, to maintain his temperature. Okay. Temperature control. I think Dr. Schill will talk a lot about temperature control. But maintaining a baby warm is very important. Because what do you do when you're cold? You put a sweater on. Does the newborn put a sweater on? No. It's not that, but you increase your metabolism. You shiver. By increasing metabolism, you need more oxygen. Can he get more oxygen when he's just not even breathing? No. So we have to keep babies warm. There are different ways to keep warm, and we'll go over that in the skill station. Denise is telling me to hurry up. Okay, this will all done in the skill station. They are different. Remember I was talking about the lid on a boiling pot? Guess what? It's the TPs. And we'll talk about that. There are different ways to ventilate the baby. There is the bag and mask. The problem with the bag is it doesn't give enough PEEP or no consistent PEEP. And if you don't bag, then there is no PEEP. So the bag, and it's starting to be less and less popular, but still a very good tool for rescue for babies who require more pressure. Because some newborns will need more pressure than what you can give with the TPs. The problem with the TPs, you do not feel what the baby needs. I don't know how many hospitals still use the flow-inflating bag, but more and more the TPs is going to take over. And we'll go over the TPs in way more details during the skill station, so I can pass over this quickly. And we can talk about Mr. SOPA, but Mr. SOPA means don't jump on intubation. Reassess how you are ventilating your babies. Ventilation is dangerous. The new edition is starting to talk about using the LMA, laryngeal mask airway. I don't know in your hospital if you are going to get that, but it's to decrease the amount of intubation. There are also studies going on that may say that it may be more efficient than mask ventilation. So this is coming, and we'll talk about this also during the skill station. Here are these famous vocal cords. They never look that good. Intubation is actually a dangerous procedure. But while you do intubation, the baby is not breathing, so you block his airway. And if you are not good at it, you may block the airway too long and produce and actually decrease the start of ventilation. We intubate only if we have the congenital anomalies, which is the diaphragmatic hernia, or we intubate if the baby will need chest compression after you having done good PPV following the algorithm of the NRP. Most of the babies will respond to your ventilation without needing intubation. Intubation is really necessary when you do chest compression. So never do chest compression if your baby is not intubated. You need a secure airway for chest compression, and you need to go zoom to 100% oxygen. So once you end up going to the intubation procedure, this is starting to be more like CPR. Use only straight Miller blades. What we have succeeded in doing though is decreasing the amount of intubation, decreasing the amount of chest compression, decreasing the amount of epinephrine that we have to give to babies, because we understand better how to do ventilation, because we understand better how to use the TPs, how to use CPAP, how to put air against the pressure of fluid. So the last question is, good job. Okay.
It was A, by the way, is the correct answer. So. But everybody's right if you choose one of those answers for this one.
They're all right.
So thank you, Dr. Wlodaver. I so appreciate the way she is able to
Thank you.
somewhat simplify a very complex process, and I think it's important for us all to understand this is incorporated into lesson 1 of the NRP 7th edition. But I think until we really understand this process, the why and how we, the why we do things, how we do things really doesn't make as much sense.